We can see you.
Okay, sorry.
Oh no, I admitted someone. Hold on.
It's okay. You could start admitting now.
Okay, it was just my name. I think it was my dad because it just had my name on it. But before we admit people, we wanted to ask you all if you would like to start by discussing the child decision and just like explaining what that means, like its connection and then I can do our brace-based agreement and talk about like how like it's a day, like it is like a kind of like emotionally heavy day for a lot of people. So like take care of yourselves and turn your screen off and do what you need to do to like show up the way you want to.
Sure, yeah.
Okay, so we can do Liz, you can do the introduction and then Olive, you can do that. And then I will go into brace base and then we'll actually introduce the team.
Cool.
So now should we admit people, Sarah?
Yeah, go ahead.
Okay. Hi, everyone, and thank you so much for coming. I'm going to introduce myself for the people who don't know me. My name is Elizabeth Balarinwa. I'm a sophomore clinical laboratory science major at Howard University, and I am a comms and development intern for GlobeMed HQ. And this is the third episode of the GlobeMed Headquarters Health Equity Speaker Series. Is there an introduction? There we go. Today, we're going to be diving into reproductive justice. Our speakers today are Alip Bamaraju, Kiera, Tony, Marilyn Dorig, and GlobeMed at UC alums, Emily Kim and Sachika. They are the members of a research team from the Ohio Policy Evaluation Network, or OPEN, who conducted a research study evaluating contraceptive policy in Ohio under the Trump administration. Today, we will be discussing reproductive justice, the reproductive justice movement, and learning about strategies about achieving contraceptive justice in our own communities.
I'm so sorry to do this. I think I have to pause for a minute and get the right slideshow up. I'm so sorry.
No, you're completely fine.
Should we introduce ourselves while they're pulling up the slideshow?
Yeah, sure.
Okay, well, since I'm unmuted, I can go first. Hi, everyone. First of all, thank you so much for being here tonight. I'm seeing some familiar faces and unfamiliar ones, so that's exciting. My name is Emily Kim. My pronouns are she, hers, and I'm currently a second-year medical student at the University of Cincinnati. And also a GlobeMed at the University of Cincinnati alum. So I'm also very excited to be here for that reason. And I'm interested in obstetrics and gynecology.
I can go next. Hi, everybody. Yes, we are super excited to be here today. My name is Sachika. I'm one of the chapter and partnership fellows at GlobeMed, and I'm also one of the members of our team at Open. I recently graduated with my master's in sociology from University of Cincinnati, where I also did my undergrad in sociology and Spanish, and my research interests are medical sociology and reproductive justice.
I can go next. My name is Kiara Tony. I am a third-year PhD student at the University of Cincinnati. I'm working as a GA on the Open project, but I also do research on race and education, specifically about curriculum and equity as far as like representation in curriculum goes. I did my undergrad at the University of Tennessee, Knoxville, where I also studied sociology and some business and leadership studies.
I can go next. My name is Marilyn Doring. I'm also a third-year PhD student at the University of Cincinnati in the sociology department. I am interested in medical sociology and reproduction. Specifically, I plan to look at sterilization in my dissertation. I got my undergrad from the University of Texas at El Paso in anthropology, and I also did my master's there where I studied doctor-patient interactions in reproductive health.
Hi, everyone. My name is Alip Bamaraju. I'm a PhD candidate in sociology, and I kind of started the project and have been really lucky to get to work with Kiara, Emily, Marilyn, Sachika since 2018 on this work. And so my focus is on intersecting inequalities in reproductive health policy focused in the United States. And so I'm a medical sociologist, but I also study social movements and the sociology of race and ethnicity. Yeah, and so I just wanted to take one moment to just recognize that Derek Chauvin, the killer cop who murdered George Floyd, has been convicted of the sort of not first degree charges that were brought against him. And so there's this, moment that we can take to kind of just think about how, the prison industrial complex is part of the thing that we need to dismantle to get to reproductive justice. And so that's part of what we'll be talking about is the sort of breadth of the reproductive justice concept and how it can apply to, narrowly focused medical studies like what we did in this project, but it expands out relatively quickly. So excited to be here.
Awesome. Sarah, we are good to go now. Awesome. Cool. I wanted to quickly draw attention to our Brave Space agreements before we get started. I won't read through them word for word, but I hope that you can review them on the screen. Like Alip was saying today can be a very emotional day for many people. And so we encourage you to do what you need to do to show up fully in the space. If that means having your camera off, you are completely welcome to do that. And we invite you to participate in the chat if that's something that you're comfortable with today. Awesome. So I can give kind of an overview of who we are. So as Emily mentioned before, we are from the Ohio Policy Evaluation Network, and we call ourselves Open. And so Open is a research collaborative of scholars who conduct rigorous, impactful, and forward-thinking social science research about reproductive health. And really our goal is to improve reproductive health outcomes and uphold autonomy for all Ohioans. And within what makes us kind of special is that we're a research collaborative across many universities in Ohio, and we're very multidisciplinary, meaning that some of us are sociologists or have a medical background, but we also have epidemiologists, lawyers, economists, And that is what makes our research honestly really fun to participate in, because there are a lot of perspectives and backgrounds to work with when we are conducting a project. So on the slide here is kind of an overview of abortion laws specifically in the past 10 years. And we wanted to kind of start with this because we know that a really common thing that people think about when they think about reproductive justice or reproductive rights is abortion, and specifically Roe v. Wade. And we hope that this graphic can kind of show you that just in the past 10 years, there have been so many policy changes regarding abortion. And so because of that, that's why we describe Ohio as a restrictive policy environment in regards to reproductive rights. And so being in a restrictive policy environment means that it can be really difficult to live and work in reproductive justice. And so we know that there's a lot of opportunity for growth in Ohio, and that is what we are striving to do through our research. So before we get started, I wanted to share a poll with you all, and it says, do you know what would happen in your state if Roe fell? I'll close it in a few seconds. Cool. Can everyone see the responses now? I'm new to this. Oh, I have to share the results. All right, there we go. Now can everyone see the results? Cool. So it looks like we're kind of split half and half between, or really like mainly a third of us would know or kind of do have an understanding of what would happen if Roe v. Wade was overturned. But a lot of us haven't thought about it or don't know where to find out. And that's kind of a common theme throughout this presentation, is that reproductive justice and contraceptive justice, in those movements, access to information is really hard, or getting access to information and learning about like what the best care is and how to advocate yourself are things that are really difficult. And so we will continue discussing that later in our presentation.
Okay, so thanks, Sachika. So I'll just provide like a little intro to reproductive justice as a concept, and just to situate it next to the idea of Roe versus Wade. So that was the Supreme Court ruling in 1973 that happened, that legalized abortion across the United States. And so after that happened, the government kind of treated abortion just like any other healthcare service, and it was covered by insurance policies. It was provided out of hospitals. It was very normal. And what happened was that there was a counter movement, pro-life counter movement, rooted in sort of white Christian nationalism that resulted in a lot of the accessibility that was available being rolled back. And so what we've seen happen with abortion rights in the United States is this sort of progressive rolling back of the rights. And so reproductive justice emerged as a movement that could address the single issue politics of Roe versus Wade, and the failure of that way of kind of approaching reproductive equity issues to actually achieve any sort of results that could benefit Black, Indigenous, and other people of color who are disproportionately impacted by restrictions on abortion. And as we'll discuss ahead, also other kinds of government policies designed to regulate reproduction. So can we go to the next slide? So this definition of reproductive justice comes from a sort of annual review that looked at a lot of different ways that people have been talking about this concept over the sort of 2 decades, from the 90s into the 2010s. And so reproductive justice is a social movement. So that means that it's sort of outside of institutions, and it's trying to shape the insiders, right? Like trying to reconfigure the state or reconfigure corporations so that they do things differently, right? And they're coming from the outside. The other part is that it's a praxis. So it's sort of a way of being. Like you can do reproductive justice work no matter what you're doing, right? And so that expansive kind of idea of like, this is something that you can always be engaged with. You don't necessarily have to be in like a movement organization to be working towards reproductive justice. And the vision idea is the sort of aspirational piece that we'll talk about in the next slide, that the sort of laying a groundwork for what we want to see happen. And so for us as researchers, reproductive justice functions as this analytic framework for making sense of injustice and inequality within the empirical situation that we're finding through our research methods. So can we go to the next slide? So this is the sort of 3 parts. There's really like 5 parts, but like the 3 things that you really need to remember about reproductive justice is that it's not just about pro-choice or pro-life. It's about the right not to have a child. So that's usually what we think about with abortion, right? The right not to have a child. But it also encompasses the right to have a child. And so we'll talk a little bit about the history of forced sterilization and eugenics in the United States. And Marilyn will tell you all about that. And the third piece is probably the most expansive part, which is the right to parent children in safe and healthy environments with sexual autonomy and with gender freedom. And so that is this sort of aspirational piece of trying to create a world where people are actually able to culturally reproduce and, bring their way of life forward without being restricted by, just being poor or, being racially minoritized within a white supremacist state, right? So, okay, so the next slide. So we focus in our project, we really are focused on the kind of top 2 principles, the right not to have a child and the right to have a child. And so what I'll just discuss briefly is, how do we connect the sort of, we're talking a lot about structural racism, we're talking a lot about how those things affect, people's lives. And so thinking about that through the lens of how the government controls fertility is this really useful way of understanding, how racism stretches from policy to people's actual lived experiences. And so the sociological term for, how gendered and racial meanings are created, because they are social constructions that have real effects, that term is called gendered racialization. And so what has happened over the, since settler colonial expansion in the United States, there has been this iterative process of sort of reproducing whiteness at the expense of Black and Indigenous people in this country. And so fertility control policies have been a critical part of that apparatus that has produced the inequalities that we're still dealing with today. And so the next slide. So I'll just talk a little bit about, like the history with abortion, and sort of like, just so you can get a sense of like, how complex policy making is and the different interests involved. So there was no state regulation of abortion in the United States prior to the late 19th century. But then within a short period of time, just a matter of decades, by 1880, every state had criminalized abortion within their state penal code. And so there was exceptions if you were able to procure an abortion from a physician, but sort of midwives and the lay healers that were common in communities were just kind of left out of it. And so what happened from 1880 until after World War II was this sort of situation where abortion was an open secret. You could get one if you were affluent. You might be able to procure one through back alleyways. It wasn't necessarily safe. But by the time World War II hit, there was increased pressure on people to delay childbearing. And so there was an increased incidence of abortion that were occurring, and an increased incidence of complications that were occurring and showing up at hospitals. And so by 1960s into the 70s, that's when you have the sort of feminist health movement that leads to abortion being legalized by the Supreme Court. And so one of the major kind of justice-related issues in the abortion policy debates in the United States is how public funding works for abortion. So in 1976, there was this effort on counter movement to remove all public funding from abortion through any state program. And that is something that is renewed in every congressional appropriation. So every 2-year budget, the entire Congress votes to ban abortion funding, right? So this is something that's about to happen even under Biden, right? And so this is one of those issues where you have this frame of pro-choice that really just leaves out the needs of low-income people who are disproportionately people of color. So alongside the same track as abortion, there was a similar kind of policy history that was happening with contraception that Marilyn will talk about.
Yes, so as Al mentioned, like with abortion, there was no state regulation or regulation of contraception prior to the mid-19th century. And then in 1873, the Comstock Law banned sharing information about birth control, but it actually broadly banned sharing information about things that were considered obscene, and birth control fell into that categorization. And then in the 1920s until today, forced sterilizations for the feeble-minded and racial others were occurring. So some of the major instances where we see that is forced sterilization of women in California, forced sterilization more recently with the ICE whistleblower that discussed how people who were being held by ICE were sterilized without consent. And the major case that kind of decided sterilization of Buck v. Bell was never overturned. And then from there, we see post-World War II modern hormonal contraceptives emerging from developments in science. But these were tested in Puerto Rico without knowledge or consent. And then the introduction of the IUD and implant and kind of questions about who those are catered to and who they're offered to, and how they affect the individuals that they are offered to. Next slide, please. So then to talk about the reproductive justice movement. So it's considered to have its beginnings in 1994 with the International Conference on Population and Development that took place in Cairo, Egypt. And then from there, 12 Black women in Chicago with the Women of African Descent of Reproductive Justice meeting that occurred. And then Sister Song, which is a very well-known organization now, in 2004, achieved mainstream discussion, and they still work towards reproductive justice issues today. So then the contemporary reproductive justice movement is informed by the eugenic history of the US. So forced sterilizations of women of color and minorities for population control from populations who were considered unfit to be parents or considered not good choices, quote unquote, for parents. And the current movement critiques repro organizations that focus on abortion rights instead of access to other issues of reproductive autonomy. So as mentioned previously, the mainstream movement talks about choice as reproductive justice, but that doesn't really encompass all of the issues that BIPOC and queer folks face when they talk about their needs.
Okay, so now I'm going to talk a little bit about contraception, like what it is, as well as contraceptive justice, and just like some more clinical perspectives. I know a good proportion of people in GlobeMed, at least when I was in it, were interested in the clinical side of reproduction and just like medicine. So I thought this would be a good inclusion into this presentation. So we can go to the next slide. So this slide just kind of details what contraception is. Most people think of contraceptives as methods and medications to prevent pregnancy, but it's actually a lot more than that. So they can be used to regulate menstrual cycles, manage different medical conditions like endometriosis, manage hormonal acne. They actually like reduce the risk of uterine cancer, as well as other things. So really, although the majority of people do use them to prevent pregnancy, there's so many people who don't use them for primarily that reason. So we can go to the next slide. This is a chart, and I think it's a little blurry, but pretty much you can find this chart anywhere if you look up like contraceptive chart. This is probably, if you have been counseled on birth control, this is probably the way you were counseled on it, and it's called tiered effectiveness. And basically, providers will go through your different options in order of most effective at preventing pregnancy to least effective. And I'm going to talk about why this is problematic. So we can go to the next slide. This slide is basically just saying that when, and I know it says women, but I think we want to acknowledge that not just women are on contraception. It's generally people with uteruses, and hopefully in the future it will be everybody can have access to some form of contraception. So this slide is detailing that when people's first choice of contraception was granted by a provider, 72% of those people were still continuing that medication or method 1 year later. Whereas if a provider denied a person their first choice in contraception, only 8.9% of people were still continuing that method. Therefore, you know, I think the principle of like, you know your body best is a good principle to follow, and especially as a clinician to work with your patients and honor what they see as best for their lives and for their bodies. We can go to the next slide. So here's a couple reasons why most effective is not always best. And this kind of goes back to all the different reasons that people use contraception. So not only do they prevent pregnancy, but they can also have a pretty big impact on your pleasure and your sex life. They can be very expensive based on the method. If you live in a rural area, not all clinics have all of your options. So that's getting in a little bit more into like the justice side of it, which we'll talk about in a little bit. And then other things, just some people want to avoid using hormones. It's just like a personal choice. Some people want to prevent the transmission of sexually transmitted infections. And for that, you'd have to use a barrier method like a condom instead of, you know, a pill. And so this is basically just saying that if you become a provider in any way, tiered effectiveness is really not the best way to present contraceptive options for your patients. We can go to the next slide. Okay, and so this is just a definition of contraceptive justice. It's so that all people having the social, political, and economic power, rights, access, and resources to receive contraceptive and pregnancy prevention care, that is. And then there's a whole list of conditions that are important to achieving contraceptive justice. I'm not going to read all of them to you. I think you can read them for yourself, but you know, we want to focus as providers and as a society really on being the most inclusive, the most affirming, and the most empowering to our patients that we can. Sorry, I'm reading the chat. Not only if you're a provider, especially important if you are a healthcare provider, but really for anybody, switching our language to being more inclusive, especially being gender neutral, is incredibly important. These are some things that, some of these words, like I personally did not think about until I got into medical school. And so I thought it was really important to share some of these. So for example, instead of, you know, saying penis, vagina, vulva, we can say front parts or front opening. So you can ask patients, do you have sex with your front parts or your back parts? And that just keeps it really neutral and depersonalized as well if people experience any dysphoria with their bodies. So I think, you know, I don't know if you guys are going to have access to this presentation after, but you know, there's like a ton of resources online for ways that you can incorporate gender neutral language, especially in a medical sense. So these are just some examples. And then we can go to the next slide. Okay, so if you are interested in more clinical aspects, but even if you're not, like at some point, a healthcare provider is going to take a sexual history from you if you see one. And so this is important not only for if you want to be a provider, but if you're a patient as well. These are the things you are entitled to have when somebody's taking a sexual history from you. You're entitled to have that provider use gender neutral language. That provider should work to build trust with you over time. They should acknowledge that if you want to change your pronouns or your authentic name with them at any time, that's totally okay. And then these are just some questions at the bottom here that I think are really important to ask patients. You know, the way that providers are taught to take a sexual history is first they ask, are you sexually active? And then they say, do you have sex with men, women, or both? And I think that is really exclusionary, and a lot of times they frame it in a very heteronormative way. And so shifting our language is a really important aspect to changing norms in our society and inside of a doctor's office. Okay, so these are just more ways of asking questions. So like, what anatomy do your partners have, instead of asking, are your partners men, women, or both, or how do your partners identify? They're really just asking that for more of like an anatomical perspective. And so that's why I kind of added the anatomy question in there. And then if you ever counsel a patient or you are counseled on contraception, really the most inclusive way that somebody could ask you about that is, what do you want your contraception to do for you? And a lot of people have something in mind before they go into a healthcare provider's office about what they want their contraception to do, whether that's like controlling acne, controlling your menstrual cycle, pregnancy prevention, if it's you want it to be concealable from family members, the ability to stop contraception at any time. So with an intrauterine device or something similar, it's not as easily stopped as just you know, stopping a pill. So there's a lot of different factors that you have to consider. We can go to the next slide. Oh boy, these are just more questions. You can take a look at these after, but I think some things I want to highlight here is your physician should ask you questions that, like, I've never personally been asked some of these questions, but I like kind of wish I had these conversations with my OBGYN. So the use of sex toys, how, like, what does your like sexual pleasure look like in your everyday life? Do you even have sex? Because I think we just assume that people aren't sexually active, and that's like not true. That's not inclusive of our asexual patients, and it's not inclusive of our people who have not initiated sexual activity yet. Have you had any surgeries? What are your pronouns? And then has anyone ever made you have sex when you didn't want to? So asking if your sexual activity is by choice or circumstance, or if you actually desire sex. Some people are in abusive relationships, and you want to be able to find that out as a clinician. So just like important things that I would keep in mind if you find yourself in a clinic. Okay, I think I'm passing it off to Olive, although I don't remember.
Yeah, Kiera. But okay, so this section we're going to talk about science and justice, which is really just about what is the place of social science research in establishing and getting justice. So we'll talk to you a little bit about our project, the methodology, how we set it up, and some of the findings that we have had from our project. Also, we'll talk about the relevance of these findings to seeking justice and lobbying and things like that. I guess that'll actually be in the next section. But yeah, so this is just the combination of those two things. Passing it to Olive.
Sorry, I forgot. So we started in, it was like Trump times, right? Like taking you back to like that period where it's like, just hopeless. And so in Ohio, it was like really intense because it was very anti-abortion legislature and governor at the time. And so what we discovered, and this was sort of one of those like we found these policies kind of like after we started digging, we started finding it, but we basically found like this kind of dual policy effort that was happening in Ohio, where policymakers were incentivizing long-acting reversible contraceptives. So in this image, the little T-shaped ones, those are intrauterine devices. So they're like inserted inside of the uterus. And then the little rod thing is a implant that goes in your arm. And then the injection is like this other, like, it's basically just like an injection of hormones that lasts for 3 months and prevents pregnancy for 3 months. So the state was like really engaged in this sort of LARC first practice, like the chart that Emily showed, like tiered effectiveness, like we need to get low income people on the long acting reversible contraceptive methods. So that was like this one push. And on the other side, there was this kind of elimination of discussion of abortion. So there was a law that banned organizations who are receiving public funding from even having contracts with like the Planned Parenthoods in Ohio. And it was the Planned Parenthoods in Ohio are structured such that their abortion services are actually sort of financially separate. But that didn't matter because of the sort of proximity of their other healthcare services to abortion. So a lot of the healthcare organizations had to basically cut ties with abortion altogether, right? So there was this real state level effort focused on that. And in addition, there was a federal rule that was designed to prevent abortion referrals at publicly funded facilities as well. So we kind of named this policy paradigm the targeted elimination of abortion referrals. So it's elimination because you're getting rid of the word abortion, but then you're also creating this option that is the long-lasting reversible contraceptive method. So you're either going to, be forced to carry a pregnancy to term or be forced onto one of these LARC methods. And that was the sort of paradigm that we were identifying. And so, what we did, and to the next slide, thanks. The way that we explored this was by talking to the healthcare administrators who ran the sort of safety net healthcare organizations across the state. So these are people, they're usually kind of like more sort of like social justice oriented. They aren't getting paid a ton usually, and their jobs are, kind of like hectic, and but they're all usually like middle class people. And so they're the ones who are charged with sort of getting funding from the state and then using it to set up services that they'll provide to their community, and Ohio has a lot of rural areas, and there's actually a lot of urban areas as well. And so can we go to the next slide? So what we did was we basically just asked them tons of questions about the challenges at work and what services they were providing, and the patients that they served, the funding sources. And so we did this over the course of almost a year and a half. And so and I also had kind of some insider knowledge because I worked as an administrator for 5 years prior to starting this project. So then the next slide. So we tried to capture a sort of range of organizational types, and our sampling design was focused on trying to gather organizations from each of the 17 metropolitan statistical areas in Ohio, and I think we got to 15, so we almost got there. But basically we have a purposive sample that is designed to sort of represent the breadth of safety net healthcare organizations. But we went really deep with each administrative team. And so there's 35 organizations and 50 administrators in our sample. So the next slide. And so one of the key things that, I think we'll be reflecting on throughout is the sort of whiteness of the space. So many of the people who are working in these roles were white women, or it was a white woman who was working underneath a health commissioner who was a white man. And so there are very few situations where there was a person of color involved, and usually it was either in urban or suburban areas. So that, I think, was part of how we were thinking about this gendered racialization process happening in Ohio. So now I'm going to pass it to Emily, who's going to talk about the sort of abortion gagging side, like the abortion referrals.
Hi, I'm Emily. I'm just kidding.
Oh, I'm sorry. My bad.
No, you're okay. I wanted to start with a poll, and so I'm going to share it with you all. But we wanted to ask you, when you go to your doctor, how do you feel? Do you feel like you're in control about decisions around your care, that it's like a dynamic process or conversation of decision making that's shared, or is it more intimidating or confusing?
You're on
You're
mute.
muted.
That's funny. Okay, so it seems like there was a bit of more like some more feelings towards feeling more intimidated or confused in a space with your provider, but it's good to see that also like some people feel like they're in control of the decisions and that they can ask their provider questions openly and honestly. And so I wanted to start by kind of going into me and Emily's part of this study, which was the abortion referrals. And abortion referrals, it's not, if you've ever worked in a clinical setting, abortion referrals are never don't really look like the way a formal referral does. But when we discuss abortion referrals, it's just like, where does your doctor point you to after you have a positive pregnancy test for your provider? And so if you go to the next slide, when it comes to all options counseling, the ideal is that a person with a positive pregnancy test is provided all options immediately and then able to guide the conversation of which options they want to explore. So that means that if you receive a positive pregnancy test, you could choose to carry the pregnancy to term and be a parent to the child, or put the child up for adoption. And then there's also the option of ending the pregnancy. And if you go back to the first slide, or the previous slide. So in our organizations, we talk to the administrators to ask them about how they shaped decisions around what providers could do in terms of pregnancy options counseling. And sometimes the organizations, as you can see in the bullets, they gave no information and no referral at all. So if you received a positive pregnancy test, no information was discussed about abortion. Sometimes they engaged in counseling and gave a referral, which is much better. And then that was kind of like a spectrum. There were also organizations in the middle that they would give you information, but they wouldn't talk about it, or they would help you set up the appointment. And so there's this whole range where really ideally the best form of care is to provide all options counseling, where the person can decide what options they want to explore and then get support in further pursuing that option. But what we saw in a lot of our organizations was that wasn't the case in Ohio. And what we found was that stigma played a really big role. And so what that means is that for a lot of administrators, their stigma surrounding abortion really pressed them to imagine false policy requirements that then made them adjust the policy in their organization so that providers weren't allowed to discuss abortion with the person with the positive pregnancy test, which really ignores the reality of abortion being a commonly utilized option and really a form of healthcare that everyone should have access to if they want to use it. And we also, so through that conversation, we kind of found that we really want people to understand that the policymaking process can impact how abortion referrals are rendered or given out in Ohio or in any state really, because we found that they were imagining these false policy requirements with the gag rule being kind of impending, and adjusting the policies or options available to patients ahead of time. And so this kind of process really shows that policies that are made legislation that's passed is important, because it really does impact the kind of care that people receive even before it actually gets formally passed, yes.
Excuse me. So for my portion that I'm going to discuss, I'm going to talk about what we did with LARC. So like everybody previously mentioned, we interviewed providers of Ohio's contraceptive safety net. So some of them provided low cost or no cost services to individuals. And we found that providers perpetuated problematic LARC approaches. So when we say that some providers had kind of rules where they would have same-day insertions of LARC, but then they wouldn't have same-day removal of LARC. And that became an issue when individuals who wanted LARC removed would come in. They wouldn't be able to get it removed when they wanted. They would have to make a follow-up appointment, come back in, and then during this follow-up appointment, providers would counsel them about why they wanted LARCs removed. When patients would say, well, this is uncomfortable for me, or I don't like this method, I'd like to try something else, they would then be counseled on how LARCs are the most effective form of contraception, how they are the best form. Administrators, when they talked about about this, use narratives about patients to justify these approaches. So these narratives included discussions of patient responsibility and patient knowledge about their bodies and about LARC use. So for example, some administrators would say that patients didn't know the symptoms or the potential side effects well enough to determine whether this was caused by LARC or not. They said that patients weren't aware that their body needed to adjust to LARC use. Or they would say things like, well, if the patient has this LARC removed right now, they're up for pregnancy again, and that's what we're trying to prevent. We're trying to prevent an unintended pregnancy.
So in a paper that Olip, Marilyn, and myself are working on, we're talking about some of those narratives and framing them as a master narrative. Master narratives are a concept from critical race theory that pretty much says that these are like social myths that mute, erase, and neutralize features of racial struggle in ways that reinforce white normativity. And so like Marilyn just gave a couple examples that come up in our paper, but I'm going to focus on the master narrative surrounding infant mortality in our findings. So what we found is that the LARC first practice, which is used to combat infant mortality, has been used as like a justification for, infant mortality has been used as a justification for pushing LARC first practices. So they're basically making it out to be like the solution to infant mortality when infant mortality is a very complex is a more complex situation that requires different solutions than just stopping pregnancy altogether. So what I have on this slide is an example of one of the quotes that we have in our data. And so I'm just going to read it to you and then talk a little bit about it. So this is from one of the administrators in our study. So yeah, I've seen a huge shift, and even our administrative acceptance of LARC. And again, we've linked it to infant mortality and the effectiveness of using the most effective birth control method at preventing those unplanned pregnancies. And not only that, like pregnancy spacing, being able to do that, which has an impact on infant mortality. So everything we've done, we've just linked it to that. And actually, they've been very receptive. We've not had hardly any barriers to get that through. It's hard not to use the word push because that's just such like to push it through. We try not to use that because we don't want people to think we're pushing a certain method or that they're being pushed to. So as this quote demonstrates, they are linking various programs that they're trying to get like funding for to infant mortality in order to get funding to the clinic. And so this is something that, of course, is like a noble cause because they're trying to help relieve infant mortality, and also like they're pretty under fire as far as like funding resources go for these clinics. And so they're trying to get as much resources as they can. But at the same time, this administrator even recognizes that like this terminology of like pushing this LARC first practice onto their patients or onto their patients can be a bit problematic. And so they're trying to teeter that line of like, oh, this is a really good thing because we're able to get all this funding because people know that infant mortality is an important cause. But at the same time, they're realizing that pushing one method on people is a limitation of their reproductive freedom. You can go to the next slide. So this is two quotes from our data. So the first is, yes, and I think we have all these good intentions. Like, let's go target high risk infant mortality zip codes where it's the highest. And so a lot of times we're like, let's plan all of our events in those areas. Let's go in, let's do this and that. And then it becomes a question of, is that fair? Are we targeting? And it's a conversation that we continually have. And I'm not sure we figured out how to navigate it. So once again, this person is also like coming to terms with the fact that this could be potentially problematic considering the histories that we talked about previously in this presentation about the, as we talked about earlier, like the targeting of racially minoritized and under served communities for testing of certain products. But this is a different situation. This is kind of almost tiptoeing around like population control if the solution to lessening infant mortality rates is to let's just not have babies right now. Next quote is, we were hearing that they, the community leaders, felt very much like they had been pressured at one of our health centers. They felt as though the clinic name site had been where they were going. Somebody had kind of been encouraging LARC use, and they had to use the word pressuring. So, you know, I think that the providers may be coming from a perspective of this is so easy to use. I don't think they're coming from a place of population control on a conscious level, but I think that's how the community is perceiving it in that specific neighborhood. And so I think this quote is very important because it's considering the fact that while the providers may be coming from this place of like where a lot of us can come from, like this, I've been educated in reproductive effectiveness and, you know, healthcare, and you're not really considering the historic trauma of the community. And so this community is reacting out of both trauma and concern for not being put in a situation where they're being pressured to only have one option of reproductive healthcare. And so, yeah, move on to the next slide. Right.
Sorry, I was typing in the chat to answer questions, but if you kind of like read my previous message, then basically what I was just going to add to that is when you're like counseling patients in order to like meet their goals, I think like another good example of that is a lot of people you know, don't believe in using like a medication for contraception. They more so want to use like natural family planning, things like that. And I think those can be like looked down upon a lot of the times just because, you know, the medical community doesn't see them as like a precise way of preventing pregnancy. But if that's what a patient wants to do, it is your job as a clinician to, you know, educate them on, okay, what are the best ways that we can carry out natural family planning and still meet your goals? So I don't know if that answers people's questions. You can let me know. And the Q&A is coming up soon as well, so we can have like a larger conversation about that. But quickly, we're going to touch on some advocacy perspectives. So kind of like what we were talking about before, self-advocacy is the first place you can go if you're looking to advocate for somebody. Advocating for yourself is very important. And I have told so many people this, and it is like mind-blowing to me, like how many people don't realize that when you go to receive medical care, it's your body and you can do what you want with your body. All healthcare providers are there to do is to act as consultants, advocates, and collaborators who are there to inform you of your options so that you can make the best decision for yourself. You know, sometimes I think in the reproductive world, it's there's a lot more options, and it's less cut and dry than like say what antibiotic you want to take. That's not left up to a patient as much just because there's a lot of like knowledge barriers there. But I think like autonomy when you're with a healthcare provider is incredibly important. And you can say no to anything they do. They should be informing you of where they're touching you, where they're going to walk in the room. Like if they're going to walk behind you, they should tell you, I'm going to walk behind you now. Is that okay? You know, just like in encounters in everyday life, like consent is still like very much applicable, even though this person is like your healthcare provider. So if you don't feel comfortable around your healthcare provider, that is an issue, and you need to find a new one because you should feel completely, you're talking about the most sensitive topics in your life. And so if you don't feel comfortable with that person, you're not going to be able to like be fully transparent with them about your life, your goals, etc.
Awesome. So another form of advocacy is community advocacy, and community advocacy can look very dynamic. It could be setting up meetings with local reproductive health organizations to promote collaboration or help with resource sharing so that organizations can better serve people in their community. It can also be working with leaders to help share information to other people in the community who are then able to advocate for their needs as well. Community advocacy, in our case, we were finding that we wanted to bring our information back to the grassroots community because the academic world is very like restricted and exclusive, and we knew that just publishing our findings in a paper wouldn't reach the people who we started this research for. And a lot of times in academia, I think when you start asking questions about like, what would be the best questions to ask? What is good data? Like, how do we get there? You can get really like bogged down into the process of the scientific like exploration process and forget about why you really started. And so one nice thing about this pandemic is that we had time to slow down, and we kind of did get to have this conversation of how do we want to share back our findings and really and like connect this project back to why we started originally. And so what our team at Open is currently working on is a zine. And so we are figuring out how to, zines are like these kind of informal magazine, small paper that you, wow, that was not a sentence, but like small papers that you would distribute to share information about any like topic. And they're very common in social justice settings. So we wanted to make a zine about our findings. And so we're currently in that process of figuring out like, how do we take our data and our findings and translate those into normal everyday words so that anyone can read these like findings and use them to advocate for themselves. If they're an administrator, provide better care to people in their organizations, and so on. And so the next thing I wanted to ask is, have you ever lobbied before? Because that's our next kind of advocacy. Let me find the poll. So it's about 40-60 where a lot of us haven't lobbied. And so I wanted to go into the next, before we go into the next part, I wanted to also share that a huge part of community advocacy is storytelling and figuring out how to bring light to voices that aren't often listened to. And so Emily, you can take that to go into legislative advocacy.
Yeah, I'm so excited that the majority of people haven't lobbied before because it's, I don't know, I think it's fun. A lot of people think it's very nerve-wracking, but I would encourage you all to try it out. It's one of the great things about lobbying is you can do it as a group. And so if you have like a couple friends or like if you're part of an organization, you definitely don't have to do it alone. So here are some like very basic steps in how to lobby. And of course, there are like so many guides online to like give you tips on what to do, but this is just like a very basic list. So first you want to schedule an appointment with your legislator. You want to send an agenda beforehand that includes bill numbers, resolutions, so they know exactly what you're talking about and what you're advocating for, because really you're advocating for them to vote yes or vote no on a certain issue. If you're going with a group, you want to coordinate who will say what, and you definitely want to include a lot of personal stories and emphasize your role as a constituent. You have the most power to them in your vote and your ability to spread your story to other constituents. And so don't feel like there's a huge power differential because you are powerful in that room as well. And then you always want to end the meeting with a couple asks. So that could be, you know, vote yes on this resolution. I want you to continue to support efforts in this way. I will help you like write a bill on this. Just things like that make it very actionable. And then you always want to send a thank you and maintain the relationships. That's probably the most important part, and also the most challenging part is you want to develop a relationship with that legislator's office. And so another part is you probably won't be talking to the legislator, you'll be talking to a staffer, but you'll get to know the staffers as well. And so it's really like a continual like relationship that you'll have, but I would encourage you all to try it out. And then we can go to the next slide.
Awesome. So that's pretty much everything. I know we covered a huge range of topics today. So we started with reproductive justice and contraceptive justice, and then we went into our provider perspectives and how to advocate for yourself or how to provide good care if you are in the provider position. And finally, we went into our research study and the targeted elimination of abortion referrals. And we ended with different forms of advocacy. So there's definitely a lot of things that we can continue talking about. So we wanted to just hear what resonated with all of you. If you want to put something that new that you learned or that you're thinking about in the chat, as well as any questions that you have, whether it's about being in the academic world and being a researcher and trying to stay connected to bringing justice to your community, or just the concept of reproductive and contraceptive health or justice in general.
Feel free to unmute too.
I have a question. You guys were talking about critical race theory, and I'm wondering how Open has and plans to include intersectionality and inclusion in your reproductive justice and contraceptive justice.
So as a team in Open, we have like autonomy to do our own projects, like in our own way. And so we kind of brought in the critical race theory into our project. And I think as a result of speaking at these different open like team sharing meetings, people have probably perked their ears up more to like more critical approaches to reproductive justice. So I don't think that we can speak on behalf of all of Open and like their use of intersectionality and critical race theory, but with our projects, we definitely wanted to find a way to work that in, because myself, like I study education primarily and I am focused in critical race theory education. So I definitely saw the connection within our projects to those type of conversations. And I think as a team, we're just pretty intersectional and cool. And so we knew that we would be using that type of theory. But I don't think that we can speak on behalf of all of Open unless someone else has seen other projects using it in a different way so far.
Thank you. I think Casey said in the chat, not really a question, but I'm really excited to hear that Open is working to make your research more accessible through creative outlets like zines. And yeah, that's also something I was going to ask is how difficult do you think it's been to be accessible and digestible to people who, you know, aren't as well versed in science and stuff?
So honestly, I feel like for our group, this is the first time we're sharing our research with a group that's not immediately like necessarily in academia or research. So you tell me. But in terms of the zine design, it's definitely been a challenge because we're trying to figure out, without really having a community that we're close to, like what do people really care about within our findings, and then how do we translate that and make sense of it. So with dissemination, once we have the zine more ready to go, I think we are really trying to reach out to grassroots organizations and especially in Cincinnati to hear about how it lands with them and then possibly adjust the content so that it fits better. One idea that we have had already to figure out how to make it more digestible is that the zines can be published online like as magazines, but we're also going to make each page formatted to be able to fit into an Instagram post so that the community organizers can repost this information on their personal Instagrams, on Twitter, and stuff like that. We know that not everyone reads zines, so we're trying to make it as easily disseminable, I don't know if that's a word, to people and like providers.
We've also received a lot of like pushback in our pursuit of making the zine, because, you know, zines aren't important to like funders, and like don't get you more funding. Publications do that. And so there's like, there's a large push in academia, and I'm sure other people can speak a lot more to this than me, but there's like some, I think there's like, there can be a toxic cycle in academia to publish something in order to get more funding so you can publish something else. And so I think we're trying to break free of that a little bit and be able to like empower people in our communities to use the information that we had the privilege of obtaining.
I did have just one thing to add about, you know, I think in a lot of public health research, often you're using sort of established data sets that have been sort of constructed by some third party. And so what you're doing is sort of running these like statistical analyses, and like that's, you know, important work, but often you know, we end up, especially if we're focused on sort of like, we want to make a difference about the sort of racial disparities issues. Like you kind of end up doing a lot of sort of proof that racism exists, right? Like using these data sets. And so when you want to take a different approach and try to understand, you know, like how institutionally does racism happen? Like what's happening inside of these kind of black box organizations? You know, not just at the patient level, but at the sort of like middle level. It just takes longer. You know, like we conducted these interviews, you know, before the pandemic, and we're still trying to get the publications out. And, you know, the way that public health publishing works, it's really valued to be publishing like really close to when you collected the data. And so for deep qualitative research, it's really difficult to do that. And so, you know, I think that's one of those like structural constraints on us.
I saw there was a question on, it says like, I am curious about how we can make the general public more aware about the scientific part of contraceptives. And I guess I will attempt to tackle the question. But now that I see there's also like a real provider in this call. So if you probably know more than me, so feel free to jump in. But from my perspective, I think I immediately thought of two things. One, I think for people with uteruses especially, there's a lot of like misinformation about different contraceptive methods. I know, like just from my friends, there's a lot of conversations happening, and you know, one of my friends will be like, oh, I tried this method and I gained like 20 pounds, so like you shouldn't do it. Or I tried this method and I bled for 3 months straight, so don't do it. And like, I think it's good that we're like sharing our experiences, but also it's like one person's experience shouldn't deter you from considering that form of contraception for yourself if that's something you're interested in. Like everybody's bodies are different and like react differently to different methods. So I think that's one thing. And then the other thing is, you know, half the population, which is the part of the population without uteruses, has never really experienced the use of contraception in the way that people with uteruses do. And so I think like really the first place to go if you want to educate the public on contraceptives is to educate the people that don't generally use them as much. Because, you know, the same people there are a lot of like cis men in power who are making decisions about other people's bodies that, you know, they've had absolutely no experience in that realm. And so I think that's where we should turn to first. And then I think there's another question about the master narratives. I think Kiara or Olive would be more equipped to answer that.
Yeah, so a master narrative is essentially, in a simpler way, it's kind of like a grand stereotype. You know, like it's a master narrative is it's a way to talk about something that is racial inequality, that is racism, and like racially neutralize it, or to essentialize it, or to like, it does all these things. It's kind of like just this controlling image, or of like what is actually happening. So in our study, when we're talking about the infant-mortality master narrative, it's like, another master narrative that might be easier to explain in our study is the uneducated patient. And so that's like, it's a blanket thing that can then justify other actions, right? So when if a provider is only is not going to give them their first choice because they don't believe that they will follow the directions properly, or they don't believe that they're being honest with them, or whatever the thing is, it's like they can then justify denying them via this master narrative that is patients from Appalachia don't know a lot, don't know better, you know, they're uneducated, they are whatever. And so with the master narrative of infant mortality, it's the I can justify pushing LARCs onto these Black people with uteruses because infant mortality is an issue over there. We all know it. They're Black. Infant mortality is a thing. So we just need to give them the LARCs because that's the solution. It's like very oversimplifying this racial issue, which, as we know, infant mortality has more to do with housing, stress, food scarcity, racism in general, being experienced by Black people and leading to, racism in healthcare, leading to infant mortality, than it is, oh, because you're Black and had a baby, it's probably going to die. Like that, that's what putting LARC as a Band-Aid on infant mortality is. That's how it's acting as a master narrative, because it's oversimplifying the racial trauma that is infant mortality as a racial disparity.
Yeah, could I just add? I think there's also like, and that I think that was a really great explanation of like the breadth of what is happening. And one thing that we've been working on recently is sort of just interrogating like the political economic dynamics that are underlying the LARC sort of first stuff. And so, you know, how it works is that if you're a publicly funded healthcare organization, you're able to buy pharmaceuticals at a discount. And so you can buy these long-acting reversible methods, which are usually like $900 for like $400, and then bill people's insurance for the full 900. So you're making like 500 of revenue off of every time you're inserting one of these devices, right? And if you want to remove one, there's no device involved. So you can't make any revenue off of the device when you remove them, right? And so I think that it gets at this sort of like bigger structural issue of, you know, not having a single payer healthcare system, having this capitalist driven healthcare system creates these really problematic incentives. And so part of what master narratives do is they cover up that, right? Like they make those invisible. They make the sort of like base economic incentives that nobody would admit to be driving behavior, they render them invisible, sort of. So I think that's another piece that is important. So.
Okay, if there's no other questions, I'd like to thank you all for the presentation. Those were I feel like I'm so much more informed, and it was very comprehensive and easy to understand. So thank you for that. As we round up, I'd like to say that the Health Equity Speaker Series is going to be monthly now instead of bi-monthly. So that's very good news. So if you have any suggestions for speakers or topics, please let us know. And yeah, thank you all for coming, and make sure to fill out the feedback form that you'll get later tonight, I'm pretty sure. But yes, thank you all for coming, and thank you for the presentation. Have a good night, everyone.
Thank you.
Thank you.
Thanks so much. Bye.